righty, so it is 7 o'clock Central, and I'd like to welcome everyone to session 7 of the AO Link webinar on upper extremity fractures. And so as a reminder, and for those who have not been with us at previous sessions, AO Link is a series that's dedicated to medical students' education. So the link in this program stands for Listening, Integrating, Networking, and Knowledge. Tonight, we listen, we obtain knowledge, and we integrate, and hopefully we do some networking as well. And we've emphasized that the interactions between our colleagues are some of the best parts of the job, and so hopefully y'all see that tonight. Again, we're so grateful for the support from AO North America and the president, Dr. Rout, who is so supportive of this program and of medical student education. And Dr. Aker, our liege, our chair, he's not going to be with us tonight, but is with us in spirit and may make an appearance. But we appreciate the support and their input as well. And so again, my name's Phil Mitchell, Vanderbilt in Nashville, Tennessee, tuning in. And tonight, Augie Saez is my co-pilot, my second-hand man, the clickety-clacks, answering your questions on the Q&A box. So Augie, would you go ahead and introduce yourself, a little bit about your training, where you're practicing, and maybe a piece of advice for a medical student at a social event prior to an interview?
Yeah, for sure, especially with the interview season going on. Hey, so my name is Augie Saez. I am an orthopedic traumatologist at UC Davis, located in Sacramento, California. Born and raised in Wisconsin, did undergrad in Wisconsin, medical school in Wisconsin. Came out here at UC Davis for residency, and then down to UT Houston, same place Phil was for fellowship, and then back to UC Davis. So excited to be on here today. I think with the socials, they're going to know who you are, but they're not going to know you personally. I think it's good to have in your back pocket like a go-to little anecdote, like a little personal story, 3 to 5 minutes, some sort of elevator talk about something that you like to do outside of medical school, something that's interesting about you. It kind of helps people kind of get to know you a little bit better and just not another name on paper. So that'd be my advice.
That's awesome advice. And my next question, obviously, is going to be, what was yours? But we'll wait. We're going to wait on that till the end. So I want to introduce Jenny T. And so, Jenny, go ahead. She's our guest faculty tonight. Really excited about Jenny being on. She's dual fellowship trained, and so I think provides a level of insight as well on some of these cases. So, Jenny, take it away.
Yeah, thanks for having me. So yeah, I'm originally from California, born and raised, did all my training at UCSF. Went to, as Phil Mitchell mentioned, I'm dual trained, so I did my trauma fellowship at Seattle, and then a shoulder elbow fellowship at Mayo Clinic. I'm currently a assistant professor here on the orthopedic trauma side. Most of my practice is primarily upper extremity trauma, although I still do lower extremity stuff as well. Yeah, I'm excited.
Give us a question, your go-to interview question that you ask, or something that you think a medical student should be prepared to answer.
Yeah, there's a lot. One of my questions that I personally like to ask is, tell me about a time when you received constructive feedback and what you did about it and changes that you made.
That's great. That's a great piece of advice. So again, some of the students who are on are fourth years in the throes, and if you're not, you may get asked that in the next year or 2 years whenever you apply. So thank you both to Augie and Jenny for being here tonight. We're on session 7 of 10, so on upper extremity fractures, again, just chugging right along, and we'll keep it going tonight. Want to plug a reminder for the AO Milestones program, as AO is developing increasing resources for your surgical education. Please ask questions. Augie's on the 1s and the 2s, and he's been stretching, and I don't think he operated this week, just to be ready for this. So we want your questions. We crave them. They're excellent questions. They really drive the discussion, and so please use the Q&A box for that. And then check your email for your Credly badge, and then all these sessions are available on YouTube if you want to repeat watch, if you missed one, for your viewing later. So just as a recap for last week, we talked about ankle fractures, and again, a wide spectrum in regards to both severity of injury, but also injury patterns. And so As a reminder, in the ankle discussions, if you missed that, you can catch that on YouTube. It is currently posted if you need a refresher. So we first started by just reviewing some of the bony anatomy and some of the name structures about the ankle that are important and labeled here for discussing these fractures and fundamental to the understanding. And not only did we discuss the ankle bony anatomy, we discussed the ligamentous anatomy too. And so Taylor put together this excellent diagram going through some of the important ligaments around the ankle and understanding these relationships and how it applies to your fixation and how you're treating these ankle fractures is really critical. And so we reviewed ankle radiographs, what makes a good ankle mortise, and then we reviewed what makes a good lateral and how on the lateral you can ascertain and visualize and understand both the Volkmann fragment in addition to the Chaput fragment. And so understanding those anatomic structures and then the relationship to the ligaments is critical. And we went over a number of cases. And so we went over this case, high fibula fracture associated mortise instability on the left hand picture here with medial clear space widening that was reduced with a splint and later treated operatively. And we discussed how the ultimate goal for ankle fractures is to hold the ankle mortise in a reduced position, and whether that's open or closed treatment, that's what's driving your treatment. That's what results, that's what you're looking for in terms of success. And so we reviewed some classification schemes. We reviewed the Weber classification, and we looked at that particular case and highlighted that it was a Weber C fracture, so a fracture above the level of the syndesmosis. We reviewed the utility of an intraoperative stress radiograph. So in that same case, the fibula is fixed on the left-hand side, and then the ankle is stressed in the central figure. And you see that there's residual, still instability across the ankle mortise that is treated at that point with a screw. And then we reviewed this case. So we looked at a case that was similar, but a little bit different with some patient factors that may lead to a different course. And this case was a good example of how if the ankle mortise is not reduced, was not able to be held in a closed fashion, we see early subluxation, and this patient without operative intervention would do really poorly. We reviewed Lauge-Hansen classification, and then we reviewed some additional cases, including this trimalleolar ankle fracture treated with plates and screws. And we noted how each different fracture about this ankle got treated with an implant representative of some of our basic concepts. So we have a posterior plate on the tibia that's a buttress plate. We have a posterior plate on the fibula that's acting in an anti-glide fashion. And then we've got a compression screw on the medium malleolus. So 3 different mechanisms, 3 different fixation concepts to apply. And then lastly, we reviewed the skydiver and how these principles can be applied to get this guy back into the skies. And so we see the film on the left-hand side here, a well-molded splint followed by fixation of the fibula, fixation of the medial malleolus, and then a stress view again is used to see both medial clear space widening and then shifting of the talus, and that indicates syndesmotic fixation is needed. And so through all this, we're relying on our principles, our AO principles, and we're going to use those again tonight as we continue and discuss upper extremity fractures. So as you see again from the images here, they come in all varieties, simple to highly comminuted on the right-hand side. And so the format tonight is entirely case-based. Dr. Saez, Dr. Teeth both submitted unbelievable cases for us to discuss and really going to guide our learning objectives. So our learning objectives today focus largely on humerus from proximal to distal. First objective, just better understand the decision that guides operative and non-operative treatment. Second, approach, how to better understand the choice on which approach to use for fixing a humerus fracture. The third, implants. What implants are we using? How are we making that decision for our ultimate successful outcome of union? And then lastly, we're going to go over a few distal humerus cases to get a flavor of some elbow fractures at the end. So we're going to jump right into a case. And this is a 32-year-old patient of mine. He has this fracture of the right arm. So Jenny, start us off. How would you want a medical student to describe this fracture? And then what important patient injury details would you want in that presentation to decide how you're going to treat this fracture?
Yeah, so I think if the student is describing it, in person with me looking at the x-rays, I'd like them to start with, what views they're looking at. So this is an AP and, an attempt, I guess, at a lateral of the humerus, which demonstrates a comminuted fracture of the mid shaft of the humerus. Appears to be ballistic in nature. You can see the retained bullet fragment. So things that I'd want to know in addition to what the bone looks like on X-ray. What does soft tissue look like? What's the soft tissue damage? I think that gives you a sense of, whether or not it was a high velocity, low velocity um, uh, weapon that may change how I manage that. And then also neurovascular status, of course, especially with these penetrating traumas, what's the status of the nerves? What's the status of the blood supply?
Okay, awesome. And just kind of off the cuff, fix, operative, non-operative. We'll say the patient isolated injury, no other, ballistic wounds. He's a hardworking guy. Right hand dominance. Does hand dominance play a role in terms of the decision?
I go back and forth with that one. I used to put an emphasis on it, but one of my senior partners, made a good point that he's like, well, I need both of my arms, so dominance really doesn't matter. So I've actually had a slightly lower importance on that piece. I think if it's an isolated injury, it's relatively well aligned. I would consider at least a trial of non-op. I don't think this is one that you have to rush to make a decision on him. Maybe get to know him a little bit better as a person, and have a discussion before kind of deciding how to recommend a course of treatment.
Okay, awesome. So, yeah, I think operative treatment's on the table, as is non-operative, and so often it comes down to a discussion. You go to the bedside, you get a better understanding of the patient, what their goals are. And this particular gentleman wanted to avoid surgery at all costs. No, no consent. No, will not sign. I don't want surgery. So, we treated him non-operatively, at least for 2 weeks. And I think you said something important there. You said a trial of non-operative, and that's so critical that um, we're operating on people. It's not a rush to the decision for this. Yes, it's a ballistic fracture, but I think those can be treated successfully non-operatively too, as you're potentially going to see. So I think getting to know a patient, understanding their goals, and just being a good doctor is a critical part of this. So here's 2 weeks. I think my takeaways from this film: his alignment improved with bracing. So before he was in more of a varus position, and this overall is more acceptable. And so we kind of continued the course at this point. But Augie, I'm curious for you. This guy, pretty comminuted fracture. Maybe it's not the best brace case, but what is the ideal Sarmiento functional brace candidate? Who's the best non-operative patient? What would they look like to you?
Yeah. So when I'm thinking about, who's going to have the highest success rate with a Sarmiento brace, soft tissue envelope plays a huge role, both of the arm itself, because the brace works by hydrostatic pressure and compressing. The more soft tissue between the brace and the bone, the less you're actually getting control of the fracture and being able to hold it there. You need a patient who's kind of sophisticated, has some compliance. A misnomer is you just put the brace on and it's done. It actually requires, usually daily adjustments, and they really should be in the brace almost all the time. And so it's going to be someone who's going to be able to tolerate that for, a solid 4 or 6 weeks, which is a long time. And then, soft tissue envelope on the outside of the arm, people who have a large chest, kind of pushes that fracture into varus, which can be an issue when you're trying to hold it, from the outside. So those are kind of the main factors. There's a lot of body habitus, and then a lot of ability of the patient to kind of understand and be in control of their own care. And then someone who's able to get the clinic, because you got to follow these with some more routine clinic visits. And so they got to be understanding of that as well.
Yeah, it's interesting in general. Patients who you manage non-operatively, their fractures, it seems often you're seeing them more often in clinic. And I think that that's really critical to understand. This patient actually is going to need a lot more TLC than plating, in fact. So 2 weeks, and here's 6 weeks. And I think you see a couple of changes here at 6 weeks. Settling into a little bit of varus position, you notice that if anything, the fracture kind of returns to its initial displacement film, and it's interesting how often that seems to happen. And then you see some early healing actually laterally along the humerus there. I see some wisps of some new bone formation. The patient reflects this also clinically by being able to move their arm some without the assistance of the brace. So things are starting to gum up a little bit and heal. And so here's 6 weeks. Patient wants to continue despite some settling into varus 2 months. I did draw the angle on here to highlight the now 30 degrees of varus, but patient wants to hold. Cosmetically not terribly bothered by this and able to start functioning. And then here he is 4 months out. I see him in clinic next week for his 6 months and haven't heard much, but you can see on the 4-month films, we're starting to get bridging callus. And so successful at this point, it appears, treatment or progression towards union at this point, although we would probably term this more of a malunion. So an example of a non-operative treatment that's gone reasonably successfully, and certainly there are, I think, considerations in terms of alignment for this patient. So one
Bill,
question. Yeah, go
well,
ahead.
there's a good question that just came in, something to talk about with patients too. If you go down the non-op management, does it make future RF more difficult for given this case, or does not matter that much?
Yeah, it's great. I think it is somewhat fracture dependent on like a really highly comminuted fracture that you're probably going to bridge. I don't think it changes it that much. If it's we're going to go over a case in a second that it will highlight how it may be a little bit different if it's more of a simple fracture pattern. These patients who fail non-operative treatment, you know, I think the trial of a brace is again, I keep coming back to that term because it is a trial. And the ones who fail bracing, you know, it usually about 2 weeks, sometimes even sooner, because they come in, they haven't showered, you know, in like 10 days. The room kind of smells. They look terrible, you know, they haven't washed their hair, and they're begging for help. They're begging for surgery at that point. So the ones that fail that early trial are those that have more instability and you know early. So if I'm opening somebody up to a trial, I'm bringing back soon because I don't want them to go too long without taking a shower as well, because I feel like that's a bit torture if they kind of declare themselves early. But we're gonna hit another case that's gonna hit some of those points too. So the purpose of this case is to highlight that non-operative treatment is an option. And so we mentioned this term Sarmiento or functional brace a few times, but non-operative treatment of the humerus was pioneered by a man named Gus Sarmiento. So Dr. Sarmiento unfortunately passed a few years ago, and he was a champion of this treatment and started presenting his results in the 70s, reporting remarkable results with this bracing system. And so the Sarmiento brace, you may hear it called a functional brace, is shown here in these images, essentially 2 hard pieces of plastic which are wrapped around the arm to help maintain alignment as the fracture heals. And so the patient's allowed and even encouraged to flex and extend the elbow as this occurs. And Augie mentioned hydrostatic pressure forces. That flexion and extension of the elbow applies hydrostatic forces at the level of the fracture and promotes healing. So I think a safe modern union rate right now is hanging out around 85%. That's typically what I quote patients. Although there are some series, including Dr. Sarmiento's, who are up to 97% successful union rate. So we're going to go on to the next case. So Jenny, this case of yours, 25-year-old fall while hiking. We just talked about non-operative treatment and the possibility of Sarmiento or functional bracing as a treatment. For this patient in particular, what are some of the qualities that you're evaluating to guide that decision if they're a candidate for Sarmiento bracing? Is it the same of what some of Augie had mentioned? And then does patient preference ultimately drive the decision one way or the other?
Yeah, I think there, Augie kind of largely mentioned some of the stuff, but looking at this X-ray, right? So, commonly the X-rays, we just focus on the bone, but you can actually gather a lot of information about the soft tissue. So looking at this, you can tell this person's got a really long, thin arm. So this is what I would consider a braceable arm. The other thing is, the fracture alignment, even without a brace on or any sort of splint on, is actually pretty good. Maybe a little bit of varus, a little bit of, anterior translation of the distal segment. But the location also, I think, also makes it braceable. So it's mid portion. So if you picture the Sarmiento brace, right, this will be centered right in the brace, whereas more proximal humeral shaft fractures might not be as easily braceable just because the apex of the brace itself is in the axilla, so you might actually be worsening the deformity. So I think overall, for sure, I think I would certainly discuss a trial of non-operative for him and, see how he does.
Okay, awesome. So this is a nice segue really into indications. And so when we talk about indications, we talk about absolute indications and relative. And so some of the absolute indications or situations where you're going to see these fractures fixed are these. So open fractures like the one shown in the left-handed image, also patients with a vascular injury requiring repair. And you can see that in the right image, a modeled arm in a patient with a vascular injury that required brachial artery repair. Jenny, I'm going to have you provide some insight on this brachial plexus injury, but the other situations, floating elbow, where you've got forearm fracture and a humerus fracture, another situation where those are commonly fixed. And then where you have compartment syndrome, where you've released compartments. But Jenny, maybe speak to that brachial plexus injury. Seems kind of a strange absolute indication for fixing a humerus fracture.
Yeah, I think, it touches on the point that, if you are treating someone in a Sarmiento brace, it's an active process, right? So the patient has to sequentially tighten the brace itself, maybe daily or every 2 days to accommodate as the swelling goes down. If you actually look at Sarmiento's paper, patients have to be upright. They have to actually be able to have elbow extension and flexion because the pull of the muscles themselves actually provide that hydrostatic pressure to actually compress the bone and keep them aligned. And so when you have a complete brachial plexus palsy, when you can't do that, then you've sort of got a flail arm, and a functional brace probably won't be as successful.
That's really, really critical, a common pimping question, if you will, as well. So provides both some understanding on how bracing works, but also a really unique situation that does not occur unfrequently. So then our relative indications, first, failure of closed management. We're going to go over that case here in just a moment, but also polytrauma, bilateral humerus fractures, a compromised soft tissue envelope. So we've heard that a few times about, oh, this is a braceable arm. Oh, nice thin arm. This is one of my patients. Maybe it's just being in Tennessee, but this woman had like a pillow for an arm. It was like the soft tissue envelope was 3 or 4 inches of adipose tissue. So this is not a braceable arm. So, and there's some specific fracture characteristics we're going to touch on later. So back to the case, 6 weeks out now of bracing. So Jenny, alignment still reasonably maintained, maybe a minimal amount of errors, but nothing that upsets me at all, but not much callus formation. So what's the evaluation process at this point, 6 weeks out, with the patient?
Yeah, so he's been tolerating the brace, decently well, but still reports that the fracture itself feels unstable. And so at 6 weeks, with minimal callus on X-ray, a fracture that's clinically mobile, then we talk about then, I revisit the conversation of, well, we can continue and see how you do. There's certainly, we don't have to pull the trigger on surgery now. However, there's, a study that I think a lot of us use, that if there is continued clinical motion at the fracture site at the 6 week mark, then it's actually pretty predictive that that fracture is likely going to go on to a non-union. And so, in this case, I think the patient was sort of tired of just kind of waiting around. He's younger, had to go back to work. And so we together sort of made the decision to pull the trigger and move forward with surgery.
So when you say mobility, do you like actually take their arm in clinic and move through the
I
fracture?
do. I do.
Okay.
I warn them, of course,
Yeah.
but gently. You don't have to torque them very hard. But it's just a little bit of rotation. Um, yeah.
Okay, awesome. So we're going to start getting into some operative cases now. That you all made it through the non-op section. So Jenny, walk us through this case, and in particular, addressing that question about, is this different at 6 weeks out now? Is your thought process different? Are you seeing different things? Is your fixation different?
Yeah, I would say my fixation is probably the same. I think most humeral shaft fractures that have relatively simple fracture lines, want absolute stability, want to be compressed. So my overall fixation, construct, I think ultimately is the same. I think what's annoying is that the fracture ends are a little bit more blunted, so you don't actually get a very good, satisfying cortical read. So you can see on that first image on the left, you can see some fracture gapping, which is sore on the eyes, but that's probably as best as I could get it with, 3 clamps compressing in the planes that it needs to be compressed. There is a bunch of callus, or for him, actually minimal. So, yeah, so I would say, seeing the AO juice when you squeeze those fractures isn't quite there when you're at the 6 to 8 week mark. But I personally like, using modified clamps. So most clamps have curved pointed ends. These have been modified so that they're straight and they're placed through drill holes. So that's actually really nice to provide compression in the sort of transverse or longitudinal plane. And then a lobster claw kind of across that sort of oblique segment as well. I chose to go anterior for him. I went back and forth. I think we'll touch on this later, but he had no radial nerve issues, and for fractures that are kind of in the mid portion of the humerus, I tend to go anterior, just so I don't have to mess with mobilizing the radial nerve and risk an iatrogenic radial nerve injury. That's often something I talk about with patients as a risk of going in with surgery.
Awesome. So here we see some final results, and I think these images show an important detail. You added a screw between the left and the right, and so maybe tell us about that. Why add the screw in this case?
Yeah, so I was able, I obtained compression through the clamps and also compress through the plate. But similarly, I felt that placing an additional lag screw through the plate across the fracture just gave it kind of the final squeeze that I think it needed. So I have no question whatsoever that this was achieved absolute stability.
Yeah, question I'll ask in clinic, I'll draw out these different plating with screws and things, and one of these will be the construct with a compression plate, maybe an oblique fracture with a lag screw across it, and have the student or the resident select which is the most robust fixation, and this wins without question. So here are the post-operative excellent final radiographs, and then the 3-month follow-up with central union at this time. So Augie, any other questions to address before we hit the next case?
No, not really. And I also think, sometimes those more simple fracture patterns just don't do as well with the non-operative management. And when you can compress and get absolute stability, I think you're more likely to get union. It's a nice case.
All right, so excellent. We're going to move into the next case. And so far, we've seen a successful non-operative treatment with uh, a case that has some residual varus, but with some progression towards union. Then we've seen one that tried bracing that failed. Augie, walk me through this case, 25-year-old female. She's in a car accident. What do you see in these images? What's kind of your thought process if she needs surgery? And then I guess if she does, what indication are you applying in this case?
So I think when you look at this, I mean, just in isolation, that fracture is a little bit lower. It's a little more simple. So I'd be leaning towards operative management. But really pushing me over the edge here is that acetabulum fracture. And so that's an operative injury. The joint's not congruent. It's displaced. And so knowing the results of that, even after I fix it and get a reduction and stabilize it, she's going to be touchdown weight bearing. So not be able to put full weight on that leg, right? So she's going to need some way to mobilize. And I think if you're looking at a left leg fracture and then you got this right humerus and she can't use the right arm, it really limits the mobility options, even being able to get out of bed, transfer, those type of things. So I want to give this person some way to be more mobile, help them get out of bed, help them just get back to life, especially when they leave the hospital. Maybe they go home, they don't have a bunch of help. And fixing the arm, I know I can let them use it right away. I don't have to worry about it. They're not mobilized. There's no cast or brace or anything like that. And so it's going to just help them get back to life sooner and probably help prevent some medical complications, especially people who are really limited mobility wise in terms of pneumonias, respiratory issues, skin care.
Yeah, I think we use polytrauma as an indication, not infrequently, and almost don't think twice about it. But if you really think about this patient bracing their arm and then not really being able to feed themselves because their humerus fracture is still unstable, and then having to get assistance with self-care, even going to the bathroom because their arm isn't stable, a lot of these things, that's really why polytrauma is one of those relative indications. So that's great. I guess at this point, so you mentioned before, Jenny, the anterior versus posterior approach. You selected anterior approach on the previous case. What would you choose for this fracture?
Yeah, for this one, I would definitely go posterior. I think I'd be concerned about not being able to obtain enough fixation distally if I went anterior. There's a limitation, obviously, to how inferior you can go. So yes, my preference would be posterior for this one.
Augie, you agree?
This one, yes. I mean, I think you could fix it either way, but if I was doing this case, my preference would be posterior.
What if she had a contralateral tibial plateau that you were fixing supine?
I think, the repositioning is a thing in terms of like even for patients and just, efficiency of care. And so I'd be maybe if she has something on that same side, I'm going to fix it, maybe go anterior, but I'm probably going to just take the time, reposition, go prone. I like to treat the fractures in isolation.
Gotcha. So awesome. So here's some fluoroscopic views from that. Dr. T mentioned that modified clamp and really a workhorse that should be at the tips of your fingers for a transverse fracture.
So a quick question that came in for the med
Yeah.
students here. I think maybe Jenny, if you want to answer this, like when you're in here intraop, you've had 2 cases now, you're compressing, lagging, clamping. How are you knowing that you achieved adequate compression before you're closing a case up? Like, how do you tell?
Yeah, so I think in an acute setting, where you've got simple fracture lines, that's pretty easy. You've got basically when the fracture line disappears, I think that's a good indication. I'd mentioned sort of the AO juice, basically the blood that kind of squeezes out of the fracture lines as you compress. So that's what I would use, obviously in the acute setting, which I think, in this particular case, I'd expect to see that. There is a little bit of comminution, but generally speaking, I would see that. In the delayed setting, like in my case, I applied all the principles that I knew and I felt like I maxed out my compressions. And even though I could still see the fracture gap, I felt like I've done all I could do and hope that it healed. And fortunately, it worked out for him.
Yeah, there is a limit, I think, and one of some of the principles that you want to apply when you're compression plating are that pre-bend of the plate that we've discussed. So you can, if you don't pre-bend, you can overcompress on your near side and see gapping on the far side. So a lot of small details that can result. I think some of the simple fracture patterns are actually some of the harder ones where you really have to focus on some of those details, even sometimes harder than a bridge plate for me. So modified clamp, we compress through the plate, 4 screws above, 4 below. And so are you weight bearing these, Jenny, if you 4 above, 4 below, transverse fracture, compressed?
Yeah, I think so. I mean, her fracture pattern certainly is amenable. It's a stable fracture pattern. Once you've got cortical contact, you've got excellent fixation, excellent, compression across it. I think to answer your second question, I'd expect primary bone healing. And then, interesting enough, I think I tend to be a little bit on the conservative side, so I would actually allow this patient to platform weight bear as opposed to crutch weight bearing. And the reason for that is, the humerus sees a lot of torsional forces that I think we underappreciate. And so to me, I just feel a little bit more comfortable if they're actually loading through a platform as opposed to, wobbling on crutches.
Question just came in. What do you think about double plates to fix it? If you're worried about maybe juicing it up a little bit more, making it more stable.
Yeah, I think there's a increased trend towards dual plating, and I think there's some benefits. We'll go over a case here very shortly that can talk about some of those benefits. Jenny, do you have dual plating in the repertoire?
I do. I typically do plating if I go from the front, just because I think I've got 2 good surfaces. In the back, typically if I am doing this, I'm just doing it through a lateral paratricipital approach, or also known as the Gerwin-Hotchkiss approach. And so, when if I'm thinking about putting a plate posterior and lateral, now I'm potentially risking the radial nerve on the lateral side. And I think about the biology cost and the versus the small potential benefit of small plate in a 4-5 versus a single 4-5. So dual plates, again, I think I'm mostly reserved for the anterior approach.
Nice. And then for union rate, I generally quote like 95% operative, something like that. So you're going 85 to 95. But certainly I think it's a discussion, and I think some of the folks who want to get back to work sooner are some of the ones that is a consideration, even outside of some of the fracture patterns where you say these are the options we can brace you. And they're like, I need to be back to work in 6 weeks or I'm going to lose my job. And it's like, okay. So it's a discussion. Absolutely. So final follow-ups of the year healed. So just to recap what we discussed previously, this image on the left-hand side demonstrates an important concept in terms of what can be accessed from that anterolateral approach versus a posterior approach. And so the red box demonstrates the access from a posterior approach, and the blue box demonstrates your access from your anterior approach. And so this pictogram can be helpful to guide you as you're determining how you're going to approach and fix these fractures. And Jenny already mentioned this mid shaft, right in the middle. Your preference is anterior approach. Is that an accurate statement?
Yeah, if their radial nerve is out, then I would go posterior just so that I can look at it, do a neurolysis and stuff like that. But if it's intact, then I would maybe consider just going in the front, although splitting the brachialis feels dirty every single time.
Yeah. Augie, you have similar practice pattern.
Yeah, I mean, with the radial nerve intact, I prefer anterior mid shaft. I like the approach, and I think puts the radial nerve at less risk. But if there's a radial nerve palsy, like Jenny T said, yeah, go to the back, look at it. You're going to be there anyways.
Okay. So the second component of this slide is just understanding the available services. And Jenny spoke to this, that from the front, you have a little bit more access in terms of those surfaces. So from this approach, you can place a plate direct anterior, you can place it anterolateral, and you can place it lateral. And so we're going to go over a case that applies some of those concepts. So this
Got
is
2 questions, Phil.
yeah,
Maybe we just
please.
answer live
Yeah.
quick. So this maybe came from my mentor, but are there any situations you might use a staple to augment plate fixation as opposed to doing dual plating?
I have not used it, but they certainly try to get me to do it. So
Yeah, I mean, I've seen it for sure. I just think it's once just small point. It's basically just having a clamp on there, right? You're holding it in one spot, whereas the plate, I think, is just more stout. So maybe as a reduction agent, if I need to get a clamp off and replace it with something, but I don't find it that strong of an implant on its own.
yeah.
And then going back to that last case, why are there 4 screws for each side on such a long plate as it compared to some of our previous webinars for lower leg fractures, which seem to use shorter plates?
Great question. I think coming back to that immediate weight bearing, you'll see different practice patterns. I have partners who do 3 above, 3 below. For me, if I'm going to weight bear them immediately, I'm generally doing 4 above, 4 below with that kind of insurance policy, helps me sleep at night, that kind of thing. So, but you'll see both. And certainly if there were 3 above, 3 below, not wrong in my estimation. All right, so next case, 75-year-old guy fell from height with this injury. In addition to, he had a really terrible comminuted open distal tibia fracture, so fulfills kind of our polytrauma indication. And then notably has past medical history, end-stage renal, really a delightful guy, but not great bone at all. And so, Jenny, is this a dual plate case for you?
Yeah, I think so. I mean, I also, would actually maybe consider a nail for him as well, especially if he's end stage renal. You think about potential for wound healing problems. So with a nail, you're a little bit more minimally invasive. Yes, maybe there's more shoulder pain, but he's 75, so maybe he'd tolerate it a little bit better than someone who's younger. But yeah, I'd say either dual plate or a nail.
Yeah, that's great. Here's our case. I elected to do dual plate. I think the benefits of dual plate, one, it can be a great provisional reduction tool. So here we've got a clamp on. We apply the plate in this scenario anterior, and the clamp can come off. And now on the back table, I can take my 4-5, my big, strong, dominant implant, and contour it perfectly. Maybe just with a little bit of pre-bend to be able to compress across this fracture. So It provides some additional stability, although I'd say this is a 2-7 plate, so you can see it's a little bit diminutive compared to the other one. Maybe a 3-5 plate would have been a more appropriate option for him. But it's also going to be a provisional reduction tool. So here is post-ops with a fair amount of parallax, and then his final fluoros. And so as we lay that pictogram over that case, we see that this plate, we have one that's anterior, if we just rotated the humerus a little bit, one that's anterior and one lateral, and how the concepts of understanding those surfaces of the humerus can be important as you're plating these. So all right, Augie, 35-year-old gunshot wound, isolated injury. Kind of walk us through what you see, maybe some of the considerations, patient factors, and how you're deciding operative, non-operative. We've gone over a few fairly simple fracture patterns. This is a little bit more comminuted, it seems. So how are you deciding what to do?
Yeah, so looking at this, obviously looking at the quality imaging, it's a decent AP, decent lateral flow down in the ER. You can appreciate right away just the comminution. With these ballistic injuries, you tend to see a little more of that shattering. And so you can see there's just a zone of comminution there, probably where the bullet passed. You see some metallic fragments left behind. The other thing I'm looking at is the soft tissues. So it looks like, based on what the rest of this person looks like, there's definitely large soft tissue, probably even, more pronounced because of the swelling from the injury. And so that's what I'm looking at. So when I'm thinking about how I want to fix this fracture, am I going to go for some sort of absolute stability construct, try to lag, compress all those fragments back together? Or do I want something that's going to be more relative, span it, look for some callus formation to allow it to heal? And then, of course, like, Jenny T had talked about, what do you want to know about? You want to know about the neurovascular status. This person has a radial nerve injury, palsy, which is not uncommon in these ballistic injuries, especially when you're in this kind of mid-shaft, the lower third shaft sort of fracture patterns. Not just from the fracture itself, but also from the ballistic, shock waves as the bullet passes through and makes contact, repercussions.
Yeah, I think critical concept. And as y'all are starting to present consults to your attendings, and we've brought this up before, this can be an opportunity for you to really shine, to say, this patient has a distal third humeral shaft fracture. I've assessed the radial nerve. It is intact. I assessed EPL 5/5 strength, and they've got intact sensation on the dorsal manual. It's like suddenly you've demonstrated that you not only have identified the fracture, can describe it, but also no associated injuries, and then you can provide a really good plan. So this just demonstrates the anatomy of the radial nerve, its location and proximity to the humerus. And yet in this picture, it is in the fracture side. I feel like that's a little bit more rare. It's typically a stretch injury of the nerve. So what are you gonna do, Augie? So now we got plating. I've heard some about a nail potentially. I know non-operative. I saw ballistic earlier that was treated non-operatively. How'd you decide in this one?
Yeah, so I mean, we did see one treated non-operatively. So this is a discussion. I don't think it'd be not wrong to treat it non-operatively. You can see though she's swollen, putting the brace on right away. Probably isn't going to get perfect alignment. And then you just got to follow it. She's got these bullet wounds, and she wants to get back to doing stuff right away. And so surgical option, I think, is going to allow her to do that, and it's going to make the follow-up care easier. And then, this is a common fracture. So I'm looking at some sort of bridge concept here, something to span it. And I think, it's not a perfect, analogy, but I think if you were looking at like a tibia that looked like this or a femur that looked like this, you would treat it with a nail. And I think nailing humeri is successful. You can get great alignment. You can get a stable construct and something that lets them use the arm right away. Because sometimes when you have a lot of comminution, you're going to have something that's not, a load sharing device, where you're relying on the implant to really reduce and hold the fracture and transmit all the force in the beginning. I think a nail is just going to be stouter. It's down the center of axis of the humerus, right down, mechanical advantage there. And so, yeah, for me, this is going to be a nail 10 out of 10 times.
Yeah. Jenny T, I'll go ahead and say I'd probably end up plating it, but yeah, I don't think I'm as facile with the nail as Augie is. Jenny, what would you do?
Yeah, I'm also not. So my comfort is certainly plating. I think that's my tendency, but I think ballistic ones are ones that I would consider nailing.
I think after this case, I may start nailing, but so Augie, kind of walk us through. Is this like nailing a femur, kind of the same set of steps here?
Well, I think the principles are the same. So when I talk to trainees, it's all about start point and end point, right? Because your nail's going to follow the path of your guide wire and what you ream. And so it's not just nailing a long bone, it's reducing a fracture and then nailing. Now, the nice thing about the nail is it allows you some flexibility. You can use the nail as a reduction agent. But the key is I want an on-axis start point. You can see that in the upper left. We opening ream, we pass the ball tip guide wire, we pass it down. It's through the fracture. You can see it's not reduced. Now here's an x-ray with me, my hand in there, reducing the fracture while it's reamed. This is all closed. And you can see then the nail follows that path and restores the alignment.
So
yeah.
final humerus x-rays, anatomic. I mean, this is a great case. And I just want to note that Dr. Sias does practice in the essential humeral nailing mecca of the world. So it's great to see this case, and we get 3-month follow up with essential union at this point. So really a great case. So we reviewed the treatment options now: plating, non-operative, plating, dual plating, nailing. So Jenny, let's bring it home. Case of your 65-year-old female with this fracture after getting her nails done. So is it operative? And then what's your approach, thoughts on implants?
Yeah, so she's got a, segmental humeral shaft fracture that primarily involves, the proximal segment. I think what ultimately tipped my recommendation for surgery for her was the fragment where the deltoid tuberosity is still attached, or, the fragment with the deltoid tuberosity. So I think what we've seen in the literature and what we maybe have seen in our practice is that oftentimes, the pull of the deltoid really kind of keeps that piece laterally displaced. So I was worried that, the likelihood that she would go onto a non-union would be higher. She's also a little bit more, generous in the chest area. So also a really challenging arm to brace, and she was miserable and uncomfortable. So, it does extend proximally. So for sure I would go anterior. So I'd want to get plates that go into the humeral head. And then, kind of protect her whole humerus. She is older, so the likelihood she falls again in her lifetime is pretty high. Yeah.
Okay. Awesome. So little 3D reconstruction here. Again, coming back to that diagram with the red box and the blue box, we're in the anterior based approach. We're trying to get more proximal fixation, so it's going to be an anterior based approach. And so here's some fluoro showing reduction of the humerus. We see some lag screws, multiple small lag screws, really nice application there, and then a plate applied in that lateral position with fixation up into the proximal humerus, and a really excellent final result. So just to kind of sum things up before we get to the teaser case. So first, non-operative treatment's viable. And so humerus fracture been treated non-operatively for thousands of years. And so with bracing, the quoted rate at this point that I'm utilizing is 85%. But there are indications, both absolute and relative, and we reviewed some of those. We talked about some of the indications for anterior-based or an anterolateral approach versus posterior. And then we've got implants available to us, and really it's about achieving the goals of getting the bone to heal. And you can do that with a plate or a nail. And then it's important to remember that the radial nerve is at risk. And in your presentations, I'm just waiting to hear that. Okay, what's the status of the radial nerve? So teaser case, here we go. 48-year-old guy, but neither Jenny or Augie have had access to this. This has been under lock and key. So you're getting it fresh here. So 48-year-old guy, right hand dominant. I present with this injury, completely nerve vascular intact. I'm talking 5 strength in everything. No numbness, no tingling, pulse fantastic. Has a single entry site, which is curious because the only way I can think of this bullet getting lodged into the proximal humerus is kind of more of a pinball mechanism. So he's got this fracture. So overnight resident sees it, puts on a coaptation splint. Alignment, yeah, like maybe like 90 degrees of Eris or something like that, 70. So just maybe not great for non-operative, but so it's an option, it's a discussion. So um we've talked about how to fix it, how we could fix it. So Jenny, what would you do?
Yikes, I'd send it to you. No, I'm just kidding. Um, yeah, I think the distal segment looks really short. So if you talk about nailing, certainly antegrade nail, I think is out. I think someone asked about retrograde nail. I'd probably tap Augie to see if this is if we could do it with a retrograde nail. But I think it's really comminuted, 50% of the humeral shaft is involved, malalignment in the splint that I think I would probably lean more towards a recommending surgery, bridge plate construct of some sort from the back.
Augie, did you ask yourself the retrograde nailing question?
Yeah, I know. I was hoping someone would bring it up. No, I
What would you
was
do?
legit. Here's the thing. I mean, I would get a CT on this person, look, because I see there's that little fracture line. It's hard for me to tell if it's complete or not complete, but it's getting pretty close to like around fossa, which is gonna be the start point. When I see this fracture, I want to nail it. If it can be nailed, I mean, I think a nail is gonna be awesome for it, but I just don't know. That fracture looks pretty low, and I see that fracture line. So if I see any like non-displaced fractures going into the lecranon fossa, I'm just not gonna nail it because that's gonna be an issue. Atrophic fracture, loss of containment, loss of fixation. But I do think if I can nail it, I'm going to try and nail it. And I agree, retrograde would be the way to go because you need to control that short segment. You need to make sure that's where you prioritize getting fixation. And I think, with the retrograde nail, you don't have, there's this concept like it has to be completely buried. You can't see it all. There's actually room in the lecranon fossa. A lot of people who fix distal humerus know this too. Sometimes you get screws into the lecranon fossa, that there's room there. So it just depends. And also, the nail you're using and where the interlocks are. If that is a fracture line that's extending down into it, though, then I'm thinking about some sort of minimally invasive plating here. I think I'm not going to try to open this fracture. I just don't think you're going to gain anything from that. It's comminuted. It's going to be messy in there. And so that'd be my backup option.
Yeah, I think again, just coming back to the basics, it's like how do we want this bone to heal? And we want relative stability, secondary bone healing. The best orthopedic surgeon in the world could not lag this humerus back. So this is what we did, kind of similar to what has been mentioned, posterior approach, certainly because of the limited distal real estate. Patient was placed prone, two windows, incision distal, and then the plate was applied in kind of a more of a MIPO fashion, then made a separate window proximal. Could run my fingers underneath the nerve, feel the radial nerve, make sure that we're safe, and then apply screws above and below. And so here's kind of his final construct. As you work more proximal, that's an area of the humerus from the back I'm not used to going. So you got to work under the axillary nerve at that point. So that was a critical component. And so he's now 3 months out, again, come back to the operative indication. We let him move his elbow from day one. So he's got great range of motion, elbow, shoulder. We're just starting to let him bear some weight. 3 months out. I'm holding out hope, but we're waiting for that callus ball to start forming. So we're going to spend a few minutes on distal humerus fractures. Any questions, Augie, before we?
Yeah, I'm answering one. Then there's a very specific question. It's kind of a little separate case. So I'll just give you the details. So this person was in the ER. It's a 96-year-old, hypertension, type 2 diabetes, walker dependent, but lives independently, ground level fall, surgical neck fracture, BMI normal limits. They went non-operative management, discussed the considerations. I think this is a little bit different because we're talking proximal humerus in an older patient, but talking about considerations of bone quality, surgical tolerance, past medical history, age, quality of life. I think that can apply to really any fracture.
Yeah, definitely. I think proximal humerus in that scenario where a lot of proximal humerus fractures can be treated non-operatively, and some of the same considerations here. Is it a braceable arm? These things that we are talking about aren't going to apply as much. So I think I just last week in clinic, terrible proximal humerus, terrible distal humerus in the 95-year-old, both treated non-operatively. X-ray looks, it's not pretty, but she's very functional. It's like the demand is different. So I think that's an important consideration. We treat each patient independently. So we're going to talk about distal humerus fracture.
One last quick question.
Yeah, please.
attendee. Last case, the one we just talked about, external fixation. Anyone use that to treat common humeral shaft fractures definitively?
I have not been using it definitively. I prefer like more of a MIPO plating in terms of getting, for a fracture like that, it's going to take months and months to heal. So it's really about the durability of X-Fix. You're going to see X-Fix most commonly used in situations of like vascular repair, maybe a compartment syndrome that you release and then you put an X-Fix on, you come back later and fix it, that kind of thing. So it can be a nice temporizing measure. And there are probably some there probably are some indications where it'd be treated definitively, but it had to be pretty specific. I can't think of any patient that comes to mind at this time. Distal humerus, we're going to hit two cases. And so this is the first one, 18-year-old gal with this fracture. And so, Jenny, looking at this pattern, what are you asking for from your resident in the ER in terms of, do you need additional workup? Any specific things about this patient you want to know?
Yeah, certainly. I think I would want to know, is it open or closed? Commonly, if they are open, there's a poke hole wound posteriorly, and that's usually a result of the proximal segment that sticks out of the skin. It is an intra-articular fracture, so some people would actually just get traction view, X-ray in the ER, and that's all the information they need. Personally, I actually really like CTs with 3D recons, and so that's typically my workflow as opposed to asking the residents to get a traction view. And then, of course, neurovascular status. I think paying particular attention to the ulnar nerve, which oftentimes can be irritated and underappreciated if not carefully looked for or examined for.
Yeah, so a couple of critical components to that discussion. First, as you move down the humerus, the considerations are different. So if a resident's presenting it to you and they comment on the ulnar nerve as opposed to the radial nerve for a distal humerus fracture, if I in my situation, like, this person knows what they're talking about. They've read up, they clearly are on a good trajectory and they're going to get to nail the next femur without Mitchell being all over them. So I think those things are really important, both for understanding what the patient's injuries are, but also in discussions with your faculty. So we got a traction view on this patient. This is what a traction view can add for you. It can give you a little bit better understanding. You say this is a simple intra-articular split. And when we look at this and we start talking about operative planning, we come back to the basic concepts where we say primary or secondary bone healing. Well, this is an intra-articular fracture. So I want primary bone healing across the articular segment. I want to get no callus with that. I want to apply my implants and compression and be able to achieve an anatomic reduction. So here are fluoroscopic views. We reduce the joint anatomically and then plate. And you'll see this really commonly. Again, this is to introduce y'all to both what some typical humerus fixation looks like, and then also what some distal humerus fixation. So some of the forces across the distal humerus versus the humeral shaft are different. So you're going to very commonly see dual plating for distal humerus fractures. And you see here we have a nice reduction across the joint, and I'd expect a little bit of callus formation with this. So Augie, this is a case of yours, 43-year-old MVC, similar but different. So kind of walk us through what your evaluation of this patient is, and then is there anything about this case that's different than the one that I just showed for you?
Yeah, so when I look at this, same thing, looking at making sure soft tissues and everything, no open wounds, neurovascular status, and still a low fracture. You maybe see some more metaphyseal comminution. And then one thing we don't really do the traction view here, but we do CTs. And what I'm really looking for in the CT is, what's the articular surface like? That's spool, the trochleocapitellum. Where's the fracture located in relative to the olecranon? Am I something I'm going to see by mobilizing the triceps? Or is this something that's going to require an osteotomy? Is there comminution, especially central comminution? Because those pieces, it's a joint. You got to get it perfect. That's what you have to do. And so sometimes you need to be able to just see better in order to do that. Especially, I find the hardest part is the rotational. Like, we're pretty good at looking at, can we get the joint to touch each other? But are we getting those pieces rotated correctly and then compressing them?
Yeah, I think the comment about the triceps and our 3D reconstructions, we're living in this beautiful era, getting these amazing images. but you have to lay the soft tissues over that 3D recon to understand that the triceps is going to be, you're going to be working around it. You're going to be looking underneath, looking around to be able to see that split. So this is a pictogram kind of demonstrating that, where the triceps is in the way. You may be limited by the olecranon in terms of what you can see, particularly centrally in the joint. So you mentioned an olecranon osteotomy and submitted this awesome case where you kind of got this division of the joint with the use of this technique, where you actually, so you cut the bone, you like sawed the olecranon, is that right?
Yeah, I mean, you're breaking bone in order to fix bone, so you can then fix bone again a little bit later. So it's an interesting concept, but it's, very safe to do. And then you can see, I mean, the other part is I do an anconeus flap elevation, but you take the triceps out of the picture. At this point, it's sawbones, right? I mean, you're seeing everything you need to see. This is now just a technical tour de force where you're getting your clamps, you're getting your wires, you're putting all the pieces back together, you're compressing, and you're just getting this thing looking real righteous.
Yeah, you got a couple of clamps,
Yeah,
looking good, but then we see this image on the right where you just see a hairline fracture, and for me, this generates a release of dopamine, and one of the reasons that I went into orthopedic trauma is the puzzle has come back together, and so this patient I suspect will do very well. So final X-rays here, and you can see the repair of the osteotomy too. We can see maybe the couple of osteons that were taken out by the saw.
Saw blade width, yeah, exactly.
Yeah, exactly. So, but really anatomically reduced at the joint, and a really fantastic result. So, coming back to our learning objectives, as we covered operative versus non-operative treatment, how to approach, and some of the implants for treating humerus fractures. We hope that you have a better understanding of these. I hope it generates more questions for you, more resources out there than we know what to do with. So we thank you all for your attention. Any other questions, Augie, that need to be addressed before?
I'm just typing this last one up about ulnar nerve, and when you're plating the distal humerus, how do you protect it, prevent friction rubbing, everything? That's actually a good question. Personally, I'll neurolyse it fully down to the FCU, first motor branch, retract out of the way, blue vessel loop. Then I put it back into its actual groove. You can see the ulnar nerve there on the left with the blue vessel loop around it. I'll put it back into its groove though on the medial side there, and just do a little like subcutaneous tissue over it. But the other option is you can transpose it.
Jenny, what do you do?
Yeah, I think what I try to do is so I do exactly what Augie does. Full neurolysis, move it completely out of the way. And then what I actually try to do before I do my deep dissection is I actually try to take the capsule and leave a cuff medially, and then reflect that soft tissue all the way off of bone. And so the idea is that as I'm repairing it back, if it's a younger patient, I now have a soft tissue sleeve that I can actually close over the plate, and then I would feel comfortable putting the nerve back in situ, and I check to make sure that it's not unstable. If it's an older patient with crappy soft tissue and the nerve's directly on the plate, then I would transpose.
Great concept. So thank you all for tuning in. Next month, pelvis fractures. And so we're going to talk about this case and what exactly happened between these two images. Was there a can of paint thrown at them? What are these clamps? So we'll talk about that, and we're looking forward to it. So again, as a reminder for you all, the OSAP is a really helpful resource through the AO website. And check your email, watch it again on YouTube, watch prior discussions as well. All these are really case-based to get the most discussion generated. I think the best part of our job is working with our colleagues, talking about cases, and best part of my month. So thank you to Augie and Jenny for joining tonight, and for all the participants. So.